Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hi, everyone, and welcome to the Chest Journal podcast. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and today I have the pleasure of talking to Dr. Barbara Weckler about her paper that's going to be coming out in the journal. Admission eosinophil count is associated with hospital resource utilization in community-acquired pneumonia, a prospective multi-center study. Welcome, Dr. Weckler, to the podcast.
Hello, and thank you very much for the invitation to join this podcast. So my name is Barbara Weckler, as you said. I'm a pulmonologist running the outpatient clinic for respiratory infections at the University of Marburg, Germany. I spend most of my time looking after patients with all kinds of respiratory diseases, including chest infections, but also COPD and asthma. And I also perform translational research studies with the main focus on outcomes in community-acquired pneumonia and asthma.
I love that. So a lot of inspiration from your day-to-day work to do this research, huh?
Absolutely. So I always think, my main motivation comes from the patient, and the message of the study should get back to the patient. That's the motivation, basically, and that gets me up and going.
Yes. I love that. So let's talk more about your work. So tell our listeners a little bit about the background of your study. Why did you decide to look into eosinophils and healthcare utilization?
There are actually two main reasons. One of that is we actually know that eosinophil counts at hospital admission can serve as a biomarker to predict adverse outcomes in community-acquired pneumonia. But as you probably know that healthcare systems worldwide are under a lot of economic pressure, I actually wanted to know whether we can use the same biomarker that we use anyway and that we measure in nearly each patient, whether we could actually use that biomarker for a second purpose and for predicting healthcare resources. And the other reason why I was interested in analyzing eosinophil counts and its ability to predict healthcare resources is that we actually know that higher eosinophil counts are associated with adverse outcomes in COPD and asthma patients. And the opposite seems to be true if it comes to community-acquired pneumonia patients. And I think that's just interesting to look into that.
It's fascinating, right? Like when I was reading your work, I was like, but in COPD and asthma is different. I love that. So tell me how you went about to look into it. A lot of very clever design went into your method. So share with me.
So first of all, we analyzed several thousand patients with community-acquired based on a prospective multi-center study, which I think makes the data quite strong because it's just not based on one single study site, but several of them. We included patients with community-acquired pneumonia, so they had to have pulmonary infiltrates on chest X-ray, and they also had to have typical symptoms such as coughing and dyspnea. And we, for example, excluded patients on immunosuppressants because of the low number of patients with community-acquired pneumonia on immunosuppressants, and also because these patients are high-risk patients, so they don't represent the normal community-acquired pneumonia patients. We also didn't include patients with tuberculosis because that's just a different set of patients, but I have to say it would still be interesting to also see whether eosinophil counts can also serve as a biomarker for outcomes as well as healthcare resources in tuberculosis patients. But that was just the reason why we didn't include these patients. And the the study design was actually simple. So we analyzed the association between eosinophil counts at hospital admission and various metrics of healthcare resources, such as intensive care unit rates, mechanical ventilation rates, and length of hospital stay. So we simply used multivariable regression analysis to analyze whether eosinophil counts at hospital admission correlate with these healthcare resource metrics.
That's wonderful. And you did all of that prospectively. So the patient got admitted to the hospital, they had a diagnosis of pneumonia, and then you and your team kept looking at their hospital stay.
Absolutely. That's a very good question and a very important point also. Yes, everything was standardized, so all patients were treated the same way and all data were captured according to a standardized protocol.
That's amazing. And how did you reconcile if patients receive steroids for severe community-acquired pneumonia, for example? Because your study included the era before we had data that in severe community-acquired pneumonia, we should be using steroids, right? And steroids will deplete someone's eosinophils at least from peripheral blood, right?
I think actually we've been knowing for a long time that eosinophil counts, depending on whether patients are on glucocorticoid treatment. Yeah. That's been known for a long time, I would say. And that's only part of the reason. So glucocorticoid treatment has an impact on outcome by itself, and it also influences the level of eosinophil counts. So there are two reasons why we stratified patients into those with and without glucocorticoid treatment. And for us, it was actually easy to find out whether patients were on or off glucocorticoid treatment. We simply relied on the patient's history and also followed the patients through the hospital stay. So we actually knew what treatment they were on.
And how about the ones who were already on steroids? Because were they then considered the immunosuppressed group that was not included?
They were not considered immunosuppressed if they had only a very low amount of glucocorticoid treatment. Okay. But we stratified patients in those who were on glucocorticoids even before hospital, or received them whilst being in hospital. So we could actually stratify patients. Did that answer your question, actually?
Yeah, absolutely. Okay, cool. Absolutely, because I did think that was an amazing thing that you all did. So I want to make sure that you talked about it. So tell us about. Oh, go ahead.
It's a very important point because we also analyzed the patient's outcomes on and off glucocorticoid treatment, and we can also see that patients have different outcomes depending on whether they are on glucocorticoid treatment or not. But that was not the main focus of the study. So we can probably cut that out, but we looked for that as well.
I loved reading that part. So that's why I want to make sure that you talked about it. Dr. Weckler, so share with me what you and your team found. So much to talk about. Tell me everything.
So the first findings were actually a significant association between lower eosinophil counts at hospital admission and higher intensive care admission rates, higher mechanical ventilation rates, and also prolonged length of stay. So at the end of the day, we found out that the lower the eosinophil counts were at the time of hospital admission, the higher the intensive care unit admission rates, and the higher the mechanical ventilation rates, and the longer the hospital stays. That was very easy, and we also analyzed that in a multivariable model to make sure that the patients had the same level of being sick. So we wanted to make sure that it's actually the eosinophil count that is responsible for the strong association between them and mechanical ventilation rates, for example.
I thought that was fascinating. Did you expect those results?
As I said before, I think we kind of expected it because there were some data showing that patients who have eosinopenia have adverse outcomes, in the sense of there were some data, but mainly also based on retrospective studies, that patients with lower eosinophil counts had a higher mortality and also have a higher rate of sepsis. So I actually expected the eosinopenic patients to require more hospital resources than the non-eosinopenic patients.
That is fascinating. So, what did anything change in your practice now that you were able to show this prospectively, that indeed, if someone comes with community-acquired pneumonia and they have low eosinophil counts, do you have like a lower threshold to send them to the ICU? Like, has anything in your practice changed?
So I think now we actually know that eosinopenia can kind of flag high-risk patients. So if I have two patients with the same number of comorbidities and one of them is eosinopenic, I would make that a high-risk patient and simply favor that patient to be put on a monitor, for example, or also to be sent to an intensive care unit over a patient who doesn't have eosinopenia. But I have to say, we also divided patients based on a threshold that we defined. We defined a threshold of 10 cells per microliter to separate patients into a high-risk group and a low-risk group. So we found that 14.2% of patients were sent to a required intensive care unit admission, as opposed to 8.5% in non-eosinopenic patients. And because you can see that patients have a higher rate of intensive care units admission, we actually see those patients as high-risk patients. But you also see that patients who who are not eosinopenic also have an intensive care rate of 8.5. So that's not zero. So I wouldn't consider them stable patients. There are more factors that we have to consider than eosinopenia in those patients to make the decision on whether to send them to intensive care unit.
That's great. I love that.
And so it's an important factor. And I think because you asked me whether it changes the strategy, I think it changes the strategy to make them very high-risk patients if they got eosinopenia. And also, I think we really have to go on and perform further studies in the future to consider eosinopenia as one factor amongst others likely, and to come up with better allocation strategies to enable clinicians to make or to use healthcare resources in a more efficient way.
Yeah, absolutely.
We have a limited capacity of intensive care unit beds, and that's why we need predictors to know which patient should go on an ICU bed and which patient shouldn't. And that's where eosinopenia can help allocate patients to the right level of care, I think.
Absolutely. I'm going to tell you that this has already changed the way I'm going to think about community-acquired pneumonia patients moving forward. Because like you mentioned before, I always cared about the eosinophils in patients with asthma and COPD. I always looked at them in patients with just regular lung infections. But now I'm going to start thinking exactly the way that you were saying, like, okay, they have very low eosinophil counts. Maybe they should be, we should check on them a little bit more often. They might decompensate. They might need ICU. And if they go to the ICU, they have a longer length of stay and might need mechanical ventilation. So I really learned that from your...
I love it. I love it. Hey, you got the message. That's great.
I really learned that from your work. I promise you.
Fantastic.
And you already mentioned that you were thinking about looking into the immunosuppressed and maybe the tuberculosis. What is next for your team?
So at the end of the day, I think we we should answer the question why eosinopenia is associated with more hospital resources and also adverse outcomes in community-acquired pneumonia. But why are lower eosinophil counts actually associated with better outcomes in asthma and COPD? And that would be the next question I would like to answer. And to me, I think we should look at whether there are different types or subsets of eosinophils that have various functions that contribute to adverse and also beneficial outcomes in community-acquired pneumonia as opposed to asthma and COPD. So I think that's a major point. And we are always talking about one eosinophil cell, but I don't believe that because of the results and the findings of this study that we are talking about, and that the findings are so different from the findings that we see in asthma and COPD patients. That would be interesting to know that. And I think that would help us move forward, maybe even allow us to come up with a biomarker, allowing us to identify high-risk patients if they turn up in hospital with community-acquired pneumonia, but also help identify patients that are more likely to respond to different biologics in asthma, for example.
Yeah, absolutely.
That would be great.
I really think it's amazing. I love that the next step is the why. I love it. Absolutely love it. Next step, the why. Absolutely love it.
Yeah.
And if you had to share 3 pearls from your work that you learned or that you really want people to know, what would they be and why?
So I think, first of all, if you've got a patient who shows up in hospital with community-acquired pneumonia, measure a differential full blood count to see whether they are eosinopenic, and consider the eosinopenia a high-risk sign of a patient that makes you make sure that the patient gets either monitored or closely followed up. That's probably the main outcome of the study. So it helps you identify the very high-risk patients with community-acquired pneumonia. But at the same time, I wouldn't want you to think that all other patients are low risk. So community-acquired pneumonia stays a disease with a generally high mortality. So take it seriously, even in patients with non-eosinopenia. But knowing that eosinopenia helps flag the high-risk patients, I think it can help predict hospital resources in a better way. And I hope we can make better use of the limited hospital resource capacity that there is.
I love that. That's amazing.
Cool.
I'm so happy you said yes to talk to me today, because I really think this work is amazing. I was always one of those people who we need a differential, because I always like to know lymphopenia. I always like to know all of these things. So I'm excited that now I have something to have in my pocket and be like, see, that there's the reason why we should be getting differentials in everyone admitted with community-acquired pneumonia. So thank you for that.
That's cool.
Yeah, I love it. Anything else you would like to leave as a message to our listeners?
To me, I really think that's the main outcome of the study. Measure eosinophil counts in patients with community-acquired pneumonia and consider it a risk sign for those patients and act accordingly. Get them to ICU or monitor station. And yes, it may help reduce mortality and may help improve outcomes in community-acquired pneumonia. I think that's the main message I'd like to give to the readers.
I love that. To our Chest Journal podcast listeners, I just had the best conversation with Dr. Barbara Weckler about her paper on admission eosinophil count is associated with hospital resource utilization in community-acquired pneumonia, a prospective multi-center study. Please give it a read, and please listen to this accompanying podcast and get your differentials for your patients with community-acquired pneumonia. It's very predictive of ICU utilization, mechanical ventilation days, and hospital length of stay. Thank you for listening. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota.